Hey, on today's show, we'll be learning about regenerative medicine, medical freedom, and how one doctor reclaimed his purpose by focusing on natural, patient centered healing.
We are born free, and we will die free. The time in between, though, that's complicated. In that time, governments, institutions, and our egos will limit our ability to find true freedom in this life. These are real stories of real people overcoming the odds, persevering in justice, and unlocking their potential. Welcome to Finding Freedom. Here's your host, John Odermatt.
Hey, what's up, everybody? Welcome back to Finding Freedom here on the Lions of Liberty Podcast Network. Got a really awesome show coming for you today. But before I intro my guest, I got to talk to you guys about my favorite coffee, which I actually have a cup of right here. If you're watching the video, you can see the steam coming off the top. It's not a prop, real coffee. Black coffee today because my cream went bad and wasn't going to go to the store. Didn't have time. So drinking some Black Fox and Sons coffee. Stephen Fox been on this show a few times. Good friend, fellow entrepreneur, fellow lover of liberty, a great guy to support. You can support him and get some great coffee at foxandsons.coffee or at Fox and Sons Coffee by going to foxandsons.com. That's FOXNSONS.com. Enter code John at checkout on an order of $40 or more and get 15% off. Okay, let's intro today's guest, and it is Dr. Howard Grattan. Dr. Howard Grattan, he is a double certified physician who spent more than 15 years in pain management before making a major shift into regenerative medicine. So instead of masking the pain, he's helping the body to heal itself using stem cells and things like platelet therapy to repair the root causes of chronic pain and help people to heal. We'll talk about his journey in traditional medicine. We'll talk a little bit about COVID and the changing landscape there, and get into what true medical freedom looks like. And we'll hear it from someone who's actually, out there practicing what they preach. So, Dr. Grattan, welcome to Finding Freedom.
Well, thank you very much, John. It's a pleasure to be here.
Yeah, great to have you on the show. And I didn't mention in the intro that you also used to have your podcast as well, and I don't have it in front of me. What was the name of the podcast you had?
It was honoring Ron Paul, even though
that's right,
he's alive, thankfully. But yeah, it was just a little podcast project trying to interview people whose lives had kind of had that shift because of the Ron Paul campaigns, like mine did. I went from just a typical Midwest Republican neocon kind of guy growing up in the terror wars. Actually, I'm older than that. So the original Desert Storm, I was all excited to see tanks blowing up back in the day. Then I was finishing up residency and fellowship in the 2007 campaign of Ron Paul. And it really changed my political and in general life trajectory as well, because I had several elements of my life that I had always thought of in different columns. One was kind of political, every little issue I thought about separately. What do I think about taxes? What do I think about, this or that? And then, healthcare, and I was a physician in my final stages of training at that time. But we have this rule: first, do no harm. And then growing up Christian, do unto others as you would have them do unto you. And then, the non-aggression principle, don't aggress on anyone. Everyone has equal rights. And exactly what rights are. If you can't have a right that imposes on other people, forces their labor. And then that kind of melded everything together. Oh, I can have a coherent life philosophy that honors both, all these different aspects of my life as a growing up Christian and as a physician. I can just apply all of that to what I expect the government to do, or in this case, not do or exist.
Exactly. It's
And
it's
then,
a libertarianism is a great philosophy. Getting it into practice, that's a whole different fiasco.
yes, yeah, and that's. But I mean, you can always, just like in health, you can always search for the ideal. You always know what
Mhm.
uh, the specific natural order should be, and then just keep striving for that.
Yeah.
Uh,
So, yeah, you mentioned Ron Paul there, and your podcast name, of course, paying homage to Ron Paul. We have very similar stories. I think we're around the same age, and I also, grew up neoconservative. I remember, when I was young, watching the first Gulf War with George H.W. Bush, and watching the newscast, and you see the lights flickering in the background as the bombs drop, and I remember being excited, and like that kind of
mhm,
through high school and growing up and into college, I kept that same sort of excitement for war. And when we went into Iraq, I really thought that we were going to create this, center of democracy and change the Middle East. So yeah, Ron Paul woke me up. I like to say that he woke me up from my neoconservative coma. And I don't know if you had a similar moment to was the Rudy Giuliani moment in 2007, was that a pinnacle moment for you, or were you already kind of ahead of the
yeah, the debates in general.
Yeah.
I think that I had seen one before, and I was on board. I don't remember that specific moment being as much of a turning point as some of the other people have kind of talked about, but just the debates in general really kind of honing things down. I remember when I was
Mhm.
watching a uh, George Bush debate and having a moment of reflection because he was debating Al Gore. And I was watching the debate, and he was dumb as a tack. And so he had a really hard time answering this question. And I was like, come on, you can do it. And then I was like, if I'm watching this to try to learn about the candidates, maybe I shouldn't be like emotionally invested in
Yeah.
if this guy has the correct answer. And so that was how I, tried to look at debates from that going forward. And then Ron Paul came along, and I was just like, well, wow, this guy is very different in regards to debates and what he's saying. Um, and I mean, it's kind of funny just about debates. I had, because after all this, I became, history and economics nerd, which is kind of the standard course. Um, and I went back and I was watching some George H.W. Bush and oh shoot, I can't remember who. It was Clinton, H.W. Clinton kind of debates. And it just, that wasn't that long ago. I mean, some of your listeners are going to be like, "Oh, that was a really long time ago." But
Yeah.
I mean, this isn't like the 50s, right? This is the 90s.
Yeah.
And just the level of conversation that they were having, I was like, wow, it has really dropped off. There was
Mhm.
no jokes about hand size. there was,
Oh, yeah.
there
It's,
was
I think Trump came along at the right time for him, because the attention span had become so short that that type of like jabbing, it's just like it lands with people, and it's the meme, that moment, that quick reel that you can get out there on Twitter and Instagram, and that's it is his style just hits perfectly for
mm,
I mean for him, not necessarily for for the future of the country. Some ways maybe, some ways no, but
right, always a mixed bag.
yeah, it's always a mixed bag with Donald Trump. I did want to make sure early on in the podcast, we're almost 10 minutes in, but I did kind of want to set the table because we are going to be talking about, medicine and regenerative care, what you do with that. But I wanted to set up the table for that conversation with you started out in pain management. So if
Mhm.
you could kind of talk about, what reasons why you had for going into that field, and, what shifts happened that, caused you to
Sure.
seek a different path?
All right. So, going way back. So I discovered a relatively small residency called physical medicine and rehabilitation, which is taking people who've been injured from essentially any cause. Like we don't discriminate on how you got injured or why you're not moving around. So strokes, brain injuries, spinal cord injuries, horrific fires, amputations, weird degenerative conditions, and um, you know, there's some elements of kind of hands-on, some procedures, but also you had to have a nice breadth of knowledge, where you had to know a little bit about just about everything, including very rare conditions, because anything weird that happens in the hospital eventually is going to end up on the rehab ward. And so, all the way from Lou Gehrig's disease to, pediatric malformations. And so you have this solid understanding of kind of musculoskeletal neuroanatomy as far as, what's how the body's supposed to work and how the body is working and adapting to that. And then trying to improve that with medications, injections, procedures, things like that. And so pain management is a branch of that where you learn some additional X-ray and ultrasound guided techniques. Back in my day, it was just X-ray. We hadn't really fully developed ultrasound guided injections yet. So the more X-ray guided injections for the spine and deeper structures. And, growing up playing video games, I just took to that like a fish in water. So I really enjoyed that aspect. The thing I didn't enjoy, that this was the early 2000s, and there was this huge shift to pain management being extremely important, which is good. But of course, the government got involved and screwed up everything, which is bad. And
how did the government get involved? Just to let our listeners know.
On, let me cook. I'm going to tell you.
Yeah, that's what it's all about. That's what it's all about.
Yeah. So there's various regulatory bodies that oversee hospital systems, and then of course Medicare is paying for a lot, and so they have, in order to be Medicare approved hospitals, they have a whole lot of influence. And so there's an organization called JCAHO, which is what credentials the hospitals, and they had decided, because of some kind of hallmark cases of undertreatment of pain. There were some cancer patients, I think, in California, where they had sued because they had to sue after the person had died, but the person was dying of cancer, and the physician had refused to write any type of opioid medications for them. So they died in a significant amount of pain. Lawsuits, and then all of a sudden everyone's like, pain is important. So JCAHO had decided that not only was pain important, but the measurement of pain was vital, and it was a vital sign. And so it was the fifth vital sign. So right up there with oxygen level, you had to write down what the person's self-reported pain was on a scale of 0 to 10. And if you did not have good pain control, then there could be consequences as far as pulling your license or regulatory concerns. And the only real treatments that anybody was looking at were these opioids. Around the same time, there was some studies that had come out about, opioids really, we know that they have a tolerance effect. But if you increase the opioids by 50 to 100%, the tolerance goes away and their pain scores go back down to whatever. So you can regain that benefit by simply increasing the amount. Well, anyone that's done any investing knows that 50 to 100% boost just a couple, 3 times, all of a sudden you're exponential as far as
Right.
your levels.
That's
Um,
that seems pretty intuitive to understand that.
yeah, and there was also some studies that kind of came out. Now it's all being shown that a lot of these studies were supported and massaged by companies like Purdue and the makers of OxyContin, and um, to give kind of more of the impression that addiction in someone who is in pain is not really a concern. And so they had their studies that showed the addiction rate was 1 or 2%. Um, now we can grab a whole bunch of addicts off the street. I'm over here in Portland area, so I've got a ton of them. And you can just say, hey, if we gave you 80 milligrams of OxyContin a day that you can crush up and snort, how likely are you to go and inject heroin? Like, man, if I'm getting the pure stuff, well, why would I need to get something from the street? Okay, well, that's not an addict in the study, right? So if you're going to the street to get even more than what they were giving you, then you didn't qualify as an addict. So that's how some of these studies kind of misrepresented the actual issues that we were developing in those early 2000s of opioids. I was never a big fan of them, but a good half of the fellows that move on to pain management subspecialty were from the anesthesia branch. Now, I love my little anesthesia brothers, but for 4 years, I was training in how to get people moving again, and they were training how to get people to stay still. So they were very comfortable with providing opioids and medications and things like that, whereas we were more the exercisey kind of bros. And so I did an anesthesia-based pain fellowship because they were the predominant ones that where these different injections that kind of developed from, off branching from the epidurals that they would do for labor.
Right.
Yeah. And so then 2000s, teens, the main emphasis was on opioid management, how to do it safely. And it was always difficult because with opioid medications and addictions and issues like that, there's always a big gray area. The vast majority of it is gray because what happens is someone who's in pain, as you take an opioid, it fills up those little pain receptors, and then your body adapts to it, not by breaking it down faster. Like if someone's an alcoholic, their liver gets huge. That's why they have a beer belly. Their liver is literally breaking down the alcohol much faster and eliminating it faster. That's not how opioids become. You become opioid tolerant. You become opioid tolerant because your body is making more pain receptors, right? And so your set point as far as what's painful adjusts and changes. So now you get what's called opioid hyperalgesia, where many things are painful, and you become more and more sensitive to pain, the thing that you're trying to get rid of, right? And so now you have a situation that if you stop the opioids, you are going to be in pain. Even young people who are addicted to opioids for the recreational benefits, if they stop, they have multiple areas of aches and pains.
That's crazy. So even if you started without being in pain, getting off of them, you would have pain.
Yes.
Wow.
Yeah. Along with other areas of hypersensitivity and, nausea, vomiting, diarrhea, all that standard stuff. Everything's just really kind of ramped up. But yeah, achy, whole body sensitivity and cold, hot, everything is just too much. And so that's a very kind of typical experience. And the flu-like nausea, vomiting, diarrhea it lasts for about a week. That's what we call the acute withdrawal. But this post-acute withdrawal syndrome, or what they call pause, um, it can last for months, where they have this increased hypersensitivity. And so now you have somebody who's had, multiple back surgeries. Maybe they had a knee replacement that's gone bad. And so they have pain. It hurts. And now you're like, okay, well, what you really need to do is for 6 months be off of this thing that for the past 3 years is the only thing that seems to help, because it kept building up and now you're on crazy doses and we need to undo all that. You need to go through, 6 months of heck. And then you'll feel mildly better than you did when you were on the opioids, because that's what the studies showed, that really changed the atmosphere in the late teens, early 20s, that made the government switch on a dime to being very restrictive as opioids. Studies came out that showed that, lots of people are overdosing. And we don't want that on our watch. So now we have to cut back. No longer the fifth vital sign, no longer important. Now we're going to have all these drug databases, all these restrictions, all these limitations, and primary care doctors are going to start losing their licenses if they're writing too many opioid medications. Even if a pain doctor was the one, oh, sure, I'll sign off on that. Yeah, you just keep them on those pain pills, and then have them see me every 6 months if something comes up. All of a sudden now a lot of people are being cut off from their prescription, and now they're going to the street, right? So before, if they're getting a bunch of pain pills, they wouldn't go to the street, because why would you? You got the pure stuff right here. And now it's like, boom, back to the street. And not just people that are abusing it recreationally, but all sorts of people that are looking for pain relief. Because heroin is, I believe it's still a prescribable drug over in Europe, right? They don't have morphine. We have morphine, but they have heroin. So, I mean, these are just opioids, right? They've been around 1,000 years in China or whatever. It's not a mysterious, magical thing. Right. It's just the opium poppy. I've even had patients that have bought huge Costco bags. I don't know if they actually sell it at Costco, but huge bulk bags of poppy seed and boil them down. If you eat a poppy seed muffin, it will show up as positive on my urine drug screen.
I've heard that. I didn't know if that was actually accurate or like an old wives' tale.
It's absolutely true. Yeah. And if you take a pound of it and I shouldn't, I shouldn't be giving people advice.
Well, people could ask ChatGPT and probably figure it out, but
yeah. If they made it in the near Stone Age, somebody can figure it out.
Yeah.
So then they had a big decrease in the amount of prescriptions that were prescribed. And then like, oh, great. Overdoses must be going down. No, they went way up. And as to be predicted, if you kind of understand how the body adapts to pain medications over time, if you stop it all at once, people are going to be significantly uncomfortable. And the only thing that's going to take that comfort away, or that discomfort away, is an opioid, because it is a withdrawal from that. Now, if people hang in there and go through it, they'll be better off in the end for the vast majority of people. But it is a miserable process that you can't really blame them for looking for other ways to kind of stifle that addiction process.
So you talked about with opioids, the cold turkey and the withdrawal symptoms with that. Are opioids something that you can do it incrementally and step it down in order to get off?
Yeah, and that's what I would try to do, and kind of ease people down over time. And then there's other things. I mean, that's where methadone comes in. Methadone is a very potent opioid medication. It's actually more potent than morphine, but it's very long lasting, right? And so you just take it once a day or even a couple times a day, and it provides a very consistent amount. And it's inherently long lasting. So it's just going to stay in the body a long time regardless. Unlike OxyContin, which is inherently a very short-acting medication, but they just put it in a pill that slowly leaks over time. And so people would take the OxyContin and crush it up so they get all that short-acting out for the nice quick hit. But methadone, no matter how you put it, you can IV, up the tuchus, by mouth, however you put it, is just going to slowly leave the body. And so that's why people would use it to dampen down the withdrawal effects and slowly bring people off opioids in general. Now there's newer ones called buprenorphine, which is an interesting medication because it's an opioid, but it fills up. It's very sticky on the little pain receptors. And so it's kind of like jealous. It keeps all the others away. And so if you take an additional opioid, it's not really going to work on those pain receptors because instead of bouncing it and activating it, it bounces and kind of sticks. Whereas with methadone, if you have a heroin addict, methadone is going to ramp up their overall opioid levels, but you can still spike it on top of that with heroin, and you may have a euphoric effect. Whereas with buprenorphine, which is newish, that's going to prevent that additional use. But all that to say, even with the short-acting pills, you can get somebody down by just saying, okay, well, you're taking 6 pills a day, break one of them in half for the next week. After that, break 2 of them in half. And you just kind of start working your way down. The body will eventually be much better. Now, post-acute withdrawal phase and the acute withdrawal phase will be less, but it's never zero after you're down to that, whatever, half a pill a day, and you stop that. It's not going to be nearly as bad, but there's still going to be, you're going to kind of miss it. And it's, it's a tough situation. So I don't like big gray areas and the vast majority of the practice. I was doing the injections. I really enjoy the injections. That was all fun and rewarding. But this opioid thing, I'm very much a people pleaser by nature. And it was not a good mix for me trying to manage opioids and help people. And, it works the best in writing opioids if you're a bit sociopathic and you just have rigid rules about how the opioids are prescribed and nothing more than this and blah, 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 blah. But, I was always a bit of a sucker for, oh man, this month I did this and it really, okay, well, we can increase it temporarily, but then we have to bring it back down. And our main goal is to get off opioids. So, with the Medicare model, I mean, you're seeing a patient every 15 minutes. It's really tough to have a conversation to change their life trajectory and encourage them to be healthy and fit and reduce inflammation by quality sleep and exercise. And you need to stop your opioids. All right, is that 14 minutes? Sweet. All right, next one.
Yeah, it's not a model that's set up to have those conversations where you can, I think a lot of people, get frustrated at doctors, and I think there's some to that. There's obviously bad doctors out there, but a lot of it is, I mean, the system is just the way things are set up with, billing and involvement with insurance companies, and it's set up for doctors to not have enough time to treat patients. What are your thoughts on that?
Oh, absolutely. Yeah, I mean, the whole system is kind of a patch on top of a patch on top of a patch. So it's a video game from 10 years ago that they're still trying to limp along with the newer systems, but patching it all together. So it's always crashing. And going way back, just in I don't know how much you want to get into, but
well, I mean, I would normally say let's get go wherever it takes us, but I do want to get to what you're doing now with regenerative care. So
right, Northwest Center for Regenerative Medicine, Vancouver, Spokane, Coeur d'Alene. Yeah, come on out and see me if you want another history or economics lecture. Yeah, so when Medicare first came out, uh, they had a hard time convincing doctors because of that darn Hippocratic oath, talking about how if there's a financial incentive, you want to make sure that your financial incentives align with the patient. You can't get involved in any type of financial system that could harm the patient.
Mm-hmm.
Right? The FTC sued the AMA back when the AMA was popular and had about 90+% of doctors belong to the AMA. Now it's about 10% because they're suckling on the government teat and do not represent medical doctors. So FTC sued them when the 80s came around and they had the HMO Act. HMOs are a product of the government. Everyone who hates an HMO, thank the government. Because to eliminate their AMA pledge, which was an adaptation of the Hippocratic Oath,
Mm-hmm.
they sued them because it was what did they say? It was like a restraint of trade, and they won. You ask the government if the government's doing the right thing. The government's probably going to say they are. So they won. The AMA had to strip that, and in comes the HMO Act. And the HMO Act was needed because they still had the rules from the Medicare, which when Medicare first started, to get doctors to sign up for it and bill Medicare, they said, we will pay you what you charge us. And about 1% of the doctors were like, oh, really? Well, let's just see. And they'd send in some crazy bill, $1,000 for a surgery. This is the 50s. Or, $1,000 or whatever for, seeing the patient, and they receive a check. Ooh, hot diggity. And then, so the Medicare made a rule that you can't charge the government anything different than you charge anyone else. Seems fair enough. So then that worked for a little while, and then still we're having problems. And so Medicare then started to publish their own reimbursement. Like, okay, we're going to pay you this for this, this for this, this for this. But they never got rid of that rule. And so there's still that rule that you can't charge anybody anything different than you charge Medicare. But nobody ever sees that amount. And Medicare says, we're going to pay doctors. We're going to do a big survey of what bills we're receiving, and then make an estimate of how much we should actually pay based on what bills we receive. So if everybody bills the government a whole bunch, they're not going to receive that. They're going to receive the Medicare rate. But maybe next year, when they do a survey, Medicare will raise their rates a little bit. And so now you've got, the typical practice, the bill rate is about 3 to 4 times. And so if you get $100 for seeing a patient, you're going to bill Medicare $400 for that 15-minute appointment.
Wow.
And then insurance companies will sign contracts with you based on the Medicare rate. Typically, they don't want to redo everything and come up with their own little codes. So they just say, we'll pay 120% of Medicare, or 115, 130, around there-ish. Like, ooh, insurance is great. They're going to pay you slightly more than Medicare rates. So everything is kind of based on that. And so that's why you see these crazy bills. Oh, we went to the hospital and they charged me $1,000 for Tylenol. Yeah, well, you're not going to actually be charged that. If you say, I don't have any insurance, what can you do for me? They're going to, oh, you don't have any insurance. Well, we can charge you whatever. If we're not billing Medicare, then you can start. And so that's why a lot of things like Crowd Health, or I do New Health, is health share things. I'm not affiliated with any of them other than I have them to treat my family. I just go and say, what's the cash price? And I just pay the cash price, and they reimburse me depending on their little restrictions and limitations. So it's just a big messed up system, and then Obamacare screwed it up even more, and now we're dealing with the consequences of that. And so, long story short, I said I was on the way out of the practice, trying to kind of quasi retire um, during this COVID thing. I think there was a huge cohort of us that just retired and just gave up. I grew up on a farm. I've always saved money, and being a doctor for 15 years certainly helped. So I could eke out an existence.
Yeah.
I wouldn't be living a doctor lifestyle. I'd be living a farmer lifestyle, but that's fine. I can do that.
Hey, don't forget that podcast income too.
$0. I mean, my wife grew up relatively poor as well. My kids did not grow up poor. I didn't clear it with them, but as far as they know, that we're middle income just fine. But we have a very humble lifestyle. That's how I was able to save enough money that I could kind of quasi retire. So I was looking at that, and I wiped out on my mountain bike, herniated a big old disc in my neck. Left arm was going numb and tingly. And so I chatted with my buddy, my partner at that time, did an epidural steroid injection, which is what I did for 15 years. It's standard of care. Didn't work that great, significant amount of pain. These are my hands. I want them to work. So I chatted with my surgeon buddy, and they were going to do a surgery. And my other friend in Spokane, Washington, he was doing the regenerative treatments, specifically ReGenexx, which is kind of the premier organization. And he was like, "No, come on up. Let me do some shots." And I was like, "All right, sure. I mean, I'm waiting for my surgery anyway. Might as well do this." And it worked.
Wow.
It fixed me. Arm woke up after, a couple of weeks or so, and it's back to normal. I just got a follow-up MRI, which I paid cash for. Whole total spine for $1,200 because I asked him for a cash price, said I didn't have any insurance, which is lower than what a lot of people's copays are going to be for a single area because of the insurance model, because the government screwed it up. Have I mentioned I don't like the government? Anyway. Yeah, and so the disc herniation had resorbed, and I was like, "What the heck are you doing?" And he was like, "You're not going to believe there's a ton of research that backs up these regenerative treatments. It's just, people aren't paying attention. It's not covered by insurance. It's not covered by Medicare, and we're getting great outcomes." So I started digging into that, and instead of kind of retiring, I've opened up a regenerative clinic so I can do this for other people. And go ahead.
And I think, looking at how the story played out. I mean, you mentioned earlier that you're a Christian. I'm a Christian as well, so I think I kind of see things through that lens. So you have a bad thing happen. You wipe out on a mountain bike. You're going through this. This trial in your life. COVID for all of us that kind of went through it, and we understood what was happening and saw the tyranny of it. It was a tough time, I'm sure, especially for you being in the medical field and dealing with that. So you're kind of at a wit's end, like, what do I do? Do I retire? I'm sure it was an incredibly taxing time for you to put salt in the wound. You wipe it on your bike and hurt yourself, and that ends up turning into, I don't want to speak for you, but it sounds like one of the best things to happen for you, and kind of give you a restart and a refresh. And to me, that just jumps out like that's God. That's how he works. So just wanted to point that out.
Yeah. I've really been kind of reinvigorated as far as my love for medicine. Getting people better. I mean, previously with the steroid injections, it would help for a while, and they'd feel good. Then they'd come back, and you do that for a couple of years, and eventually the disc problem would get bad enough, and all right, well, injection stopped working. Time for time for a surgery, and that was fairly typical. And to see a disc look perkier and happier, 3 years out, that's not something that I had experienced with my traditional steroid injections. Um, and then, treating arthritis, even up to severe arthritis, hips, knees, shoulders, rotator cuff tears, ACL tears, meniscal tears. There's a varying level of intensity of injection that you need to do depending on what the situation is. But, just as an example of kind of what I do now. So we've got little healing cells that kind of float around in our blood all the time. And they're triggered by the platelets. So you get a little cut, and at first it turns red and beefy as the little platelets set up their little clot, and all the white blood cells rush in to fight infection. But those platelets will live for a good 3 to 4 months. And as they slowly break apart, they're releasing their growth factors, platelet-derived growth factor, VEGF, which is vascular endothelial-derived growth factor, that recruit the stem cells out of your bone marrow to the area. And that's how the scar starts to shrink over time, right? And that's these little fibroblasts that are triggered to kind of pull things closer together. And so when there's a strain, a mild tear, mild arthritis, injecting simply platelets that you harvest from the blood in the area is oftentimes sufficient to just speed up the healing, fix that area. And in people beyond kind of the reproductive years, the body makes this big shift that we've all in the older group have kind of gone through, where the body stops really putting much effort into healing things up. And now it's in kind of preservation mode. So you burn far fewer calories. It's easier to put on fluff, and things just don't seem to bounce back from stuff. It's kind of a programmed situation, but you still have those cells that can encourage the body to heal up. You still have a good 80% of the stem cells in your bone marrow that you did when you were 20, and they're essentially just as effective. And they will recruit with a big enough signal. Well, the 1 times concentration of the platelets floating around is not going to do it, because it hasn't. Otherwise, it would have. But if you ramp it up to 15 times concentration or 20 times concentration that we can do in our little sterile lab, then you can get really good outcomes. If there's a big tear or severe arthritis or a tear in something that's under a fair amount of stress, like an ACL or rotator cuff, then oftentimes you'll need to, instead of just attracting stem cells with platelets, you're going to need to actually dump them on there. And to do that, you harvest the bone marrow or fat or a combination. Fat loves to grow, and so it does have a fair amount of stem cells. But the fat doesn't have a lot of the accessory like fibroblasts and other like helpful ones, along with what's called the mesenchymal stromal cells, or MSCs. And if you see any ads, or you're going to see a whole bunch of things talking about MSCs. And that's what we kind of want to get. And so the best sources are fat and bone marrow. And you got to harvest those through a needle, slurp them out in very specific ways in order to actually get the stem cells, because they're attached to the wall of the bone. And so you can't just do a nice slow pull. You've got to get multiple different areas. And the harvest is kind of almost more important than the injection. And so you want to make sure that you're going to somebody that knows what the heck is going on and how to do it properly. And then you spin that all down in the lab, spend a couple hours monkeying around with it. That's what the lab people do. Throw away the red blood cells and white blood cells, or just some of the white blood cells, keeping the mesenchymal stromal cells. Throw away the water, keep the platelets in a separate thing, And so now you've got this super concentrated mix. We draw about 120 cc's, end up with about 6 or 8. Now you can inject that into the area of the tear. And as long as there's still some scaffolding, you can get those things to grow back. If it's a complete tear, like if it's separated by more than a centimeter or something like that, there's no reason for those stem cells to grow back together. And so there has to be some connection or approximation of those areas. But if there's still a connection, even if it's a tenuous one, we've had some just really great outcomes.
But with like a full tear, like an ACL or something like that, and say there's surgery done. Well, I guess a lot of times they're using a cadaver or something to make that reconnection. But question is, with even using a traditional surgery, can you shorten the overall healing recovery process of that ACL tear by supplementing with regenerative care?
Yeah, there have been a fair amount of studies. I mean, the main thing that we try to do is avoid the surgery. It's a surgery replacement, both for knee replacements, ACL surgeries, meniscal surgeries, certainly meniscal surgeries, because meniscal surgeries are essentially on the way out. There's a lot of orthopods that are still trimming menisci, but the studies behind those are very poor as far as long-term outcome, because it's basically anytime you go into the knee joint with arthroscopes or whatnot, you're going to speed up the amount of arthritis. And trimming off portions of the shock absorber is going to really speed up the arthritis. And that's why meniscal surgeries are kind of going by the way of the dodo. But even if there have been studies of meniscal repairs where you try to sew them together and then dump in the stem cells or platelet on top of that at time of procedure, and then a month later with improved outcomes. Rotator cuff surgery, same thing. So if you have a big old gap, and the surgeon can bring those together and sew them up, and then you can speed up the healing, the likelihood of those reconnecting significantly with platelet treatments. Because like a rotator cuff tear, surgical repairs, I don't remember the specifics, but it's like a good 10-20% re-tear rate. And you can drop that significantly by adding platelets on there to kind of boost the healing. So if you've got a big old gap, there's a fair amount of orthopedic surgeons that are now also supplementing their surgeries with regenerative treatments.
Okay. So getting back to government interfering, where is this? Where is regenerative care now in regards to where maybe some other countries are with less regulations and specifically, what things can we access in the United States that you can get outside?
I'm back in the gray zone. Yes, I tried to get out, but they keep pulling me back in. So there's a lot of kind of patched together regenerative stuff.
Lost your
Got
camera.
too
There
excited, pounding the table, lost my camera. So the person that started ReGenexx was an early pioneer of regenerative medicine named Dr. Centeno and his partner, Dr. Schultz, out of Colorado. And what he did without asking anybody was, all right, I'm going to harvest these stem cells and I'm going to grow them in a lab. And then I'm going to re-inject them after I've concentrated it, grown them out 100 to 1,000-fold. And that's called culture expanded mesenchymal stromal cells. And he was doing that for years and just getting great outcomes. And then the FDA comes in and like, hey, what's going on? And he's like, oh man, it's awesome. So I grow these cells and I re-inject them, and it's all the patient's own cells. We can get all these great above. And like, yeah, so we're going to make a rule that anything that's outside of the body, even if it's the patient's own tissue, outside the body for more than 24 hours, that's now a drug or a treatment that needs FDA approval. And I was like, all right, well, can I grow them? Like, yeah, so anything that's more than minimally manipulated is now considered a novel drug or treatment, even if it's from the patient itself. Like, All right. So that's where we are in the US, and a lot of OECD countries and have kind of followed that model of you can take something from somebody, spin it down, uh, and throw away some stuff, can't add anything to it, and then inject that within 24 hours. Now, ReGenexx has a clinic in the Grand Caymans where you can still grow it out for a couple months. So you go, you get the harvest, they grow it out for a couple months, bank half of it, and then treat with the other 100 to 1,000 fold. But fortunately, for the vast majority of people, if you have a single area of concern, like a knee or a shoulder or a spine, like just the neck or just the back, hip, you can extract enough stem cells if you do the harvest right on that same day and get just as good outcomes as you would with culture expansion. Culture expansion allows you to treat everything. Right, you get 1,000-fold increase in stem cells, and then you can do both knees, both neck, shoulder, toe, whatever, all in the same day. So that's the big advantage of culture expansion. Spain never outlawed culture expansion. Panama, the Caymans, a couple different little places.
So what do you think? What do you think the reason was for the FDA making these rules? Was this to protect pharmaceuticals?
I do not know. So now, well, I will lay out what I know, and then conspiracy theorists can derive anything.
There's plenty of those out there.
So I also see, and COVID really kind of opened my eyes to that, the just systemic degradation of quality of research that has happened in the US. And, US research, as for US physicians, is the gold standard, right? We don't go looking at other countries' research, can't look at European studies, even though that's the foundation of the scientific paradigm of how you do research. But evidently they can't do it. Japan can't do it. Korea can't do it. Only the U.S. does it right. So nationalism before nationalism became a thing. But at the same time, the vast majority of research is directly or indirectly funded by the NIH. Everything's kind of going through that. FDA and NIH are strongly associated with drug and device manufacturers. On the back end, the hospital systems, which are growing because of Affordable Care Act or Obamacare, there is a direct benefit to the hospitals where they received a pay increase for everything that happened in the hospitals. Everything that happened in surgery centers or in the office received a pay decrease. So everything, and it's illegal for people to do different self-referrals called Stark Law violations. If you're in two different financial entities, but one single hospital, you can have all the layers of care and you can refer within yourself all over the place. So lots of huge advantages to a hospital system. Hospital systems are growing like gangbusters because of these. And that makes it much easier to control because now you just have little JCO rules and you control essentially the entire ecosystem of healthcare because it's being directed by these large hospital systems. So essentially fascism, right? That was how things were organized in Nazi Germany. So, how long has it been in this podcast? And we're calling someone Hitler. So that's about.
It's okay. We have anti-fascists in this country. They're gonna fix everything.
They're gonna get to the root of how hospital systems have taken over mom and pop doctor shops. Yes, that's their main goal. So on the back end, the vast majority of hospital systems, the only thing that's really profitable is orthopedic surgery, neurosurgery, and the cardiac lab. So that's one element. And the university systems do the vast majority of what's considered quality research in the United States. And they receive funds from either pharmaceutical companies to do that or the government to do that. So you have this huge incentive structure in place. And so if someone were to come in and do a procedure that cost $10,000, a single time shot that avoided a knee replacement, the ramifications of that cost savings would be seen in significant profit margin reduction of hospital systems who do the research and blah, 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 blah. So at that same time, you're seeing a large amount of the US-based research about platelet-rich plasma, bone marrow concentrate injections being very poorly done. So like in platelet treatments, dose is everything, right? Yeah, platelet-rich plasma, ReGenexx has what's called super concentrated platelets where we get a much higher concentration. And most places use a desktop system where it just automates. You put the little things in there. Not everybody does it in the lab manually like we do, but you get your little desktop system, it spins it down. And so different companies, will have different abilities in their little desktop systems to make concentrations.
Mm-hmm.
And so, 10 times concentration is fairly common. There are some desktop systems that do 1.5 times concentration. And a lot of the research in these institutions, they're using these systems that are getting 1.5 to 3 times concentration, and oftentimes they're not even recording how many platelets they actually put in there. You can run it through a thing and say, okay, well, are we getting those 10 billion platelets where, 4 to 10 billion platelets is what has been shown to improve knee arthritis. And there's been a lot of studies that if you break down, okay, well, did they actually write down how many platelets they injected in these huge studies that get published in the JAMA? There's a big meta-analysis in the JAMA that says, platelet-rich plasma doesn't work for knee arthritis. But the vast majority of those studies had no recordings of what they actually put in the knee, how much platelets, didn't record how much blood they drew, so we can estimate how many platelets were actually injected. But the studies that did say, well, we had at least 4 billion platelets, have almost universally been positive versus placebo as far as pain improvement and functional improvement.
Mm-hmm.
And so it's like, does Tylenol work? Well, maybe I shouldn't use Tylenol since it's causing autism. Evidently, does ibuprofen work? Like, okay, well, I don't know. What's the dose? Like 600 milligrams. Okay. Does 6 milligrams work? No. Right. And so so you have a huge body of research in the US, in these US based studies that, like, it's been known for a long time that the number of platelets directly correlate to the outcomes. But still, these university systems are chugging out these studies where they don't even record the platelets. And so at some point, you have to say, is that intentional? Like, what are they trying to prove? Are they trying to prove, at what dose platelet-rich plasma becomes effective? What's the threshold? Or are they trying to prove platelet-rich plasma, bone marrow concentrates don't work? Because they do also bone marrow concentrate. We harvested 10 cc's of bone marrow, injected it in the knee, and it didn't work. Well, okay, well, that's a 10th of what you should draw. And then you look at other studies like, there's a guy named Dr. Hernigau out in France who 15 years ago started a study where he harvested bone marrow and injected it into the knee, into the bones above and below the joint to restore the stem cell populations underneath the cartilage, right? Because cartilage always grows from inside out, or depending on the knee, outside in, whatever. You get the idea, hopefully. And So 15 years ago, he took 60 patients that had bilaterally equal knee arthritis. And the plan is you're going to do a knee replacement on one knee. And 3 months later to 6 months later, once you've recovered from that, you do the knee replacement on the other knee.
Mhm.
That's very standard. And so he's like, okay, well, let's just randomize. One knee gets a knee replacement, the other knee gets the stem cell treatment, or the bone marrow concentrate. There's FDA's made some weird rules about calling something stem cell. So bone marrow concentrate. You inject that into the bones above the cartilage and just see what the outcomes are. And then he followed them. And the people had quote unquote, needed a knee replacement at that day 0. And in that group of 60, the first person that actually needed a knee replacement ended up about 6 years out. Now, also about that 6-year mark, somebody who had a knee replacement, one of their knees went bad and they needed a knee replacement. And so it went. Somebody that in the stem cell group needed a knee replacement, but also about the same time, somebody needed a revision, which is much bigger surgery. So the conclusion was that having a knee replacement didn't really prevent you from needing a knee replacement versus having intraosseous stem cell injections. And 15 years out, some 80% reduction in need for knee replacements. And at those 6, 7, 8, 10-year marks, when people were asking for knee replacement in the stem cell side, because they were in that study, they weren't offered, hey, let's do the stem cell again. They were offered knee replacement. So, if you're a 70-year-old and you're looking at a knee replacement, 6 years out, you're 76. Would you rather have a knee replacement at that time or another stem cell treatment? It was, and so that's one of the best studies, but it was in French, came out of France, ooh la la, and so it's didn't have nearly kind of the impact that you would think.
People don't take the French seriously, do they? That's what it is.
Well, I mean, U.S.-based physicians are trained very specifically that, you look at U.S.-based research.
Mm-hmm.
And so, at some point, it's like, is the poor quality research coming out of the U.S. accidental? They just don't know what the protocols are. They aren't paying attention. Or is it intentional because the business model of the hospital would kind of fall apart if people transitioned from $100,000 surgery to, $10, $12, $15,000 stem cell procedure. But I'm not saying that.
Yeah.
I'm just laying out.
Of course not. Yeah.
I'm just laying out what the various incentives of the various actors are.
Somebody else might say that, but we're not saying that here. But we are running up here on the end of our time. But I wanna give you a chance here to plug your clinic, regenerative and performance medicine, and if there are people, there very well could be people listening who are in your area that might need some help.
Yeah, people oftentimes will fly in, doing somebody from Australia next week, people from Alaska. So we can certainly set up a telehealth and kind of go over your films, images, if you'd be a candidate, what level of treatment would you need? Are you able to get by with the less expensive platelet treatments? Do you need to do the bone marrow harvest? What are the risks of all that? Yeah, I'm at Northwest Center for Regenerative Medicine, NWC, the number 4rm.com, and partnered with Center for Performance and Regenerative Medicine, CPRM. But yeah, be more than happy to at least chat with people and give you an idea, give you some indicators. I mean, because there's a lot of people that are now out there. A lot of people will have somebody that's doing something similar to me within a couple of hours of them. But they'll also have a lot of people that are, working out of a chiropractor's office that are doing crap. There's a lot of snake oil. There's a lot of promising living stem cells out of a vial, which has almost universally been shown they're all dead or they're actively dying, and you can't actually grow them. They have some of the growth factors, like the platelet-derived growth factor, in there. So some people for mild conditions may have benefit from those stem cell vials, but not nearly the same as restoring your natural level of stem cells in the area.
It's always a shame, just to interject real quick, when you do have the snake oil come in and people, kind of doing things half-assed, because that
Yeah,
hurts the entire industry. I mean,
yeah, yeah, and that's something that you see in unregulated type situations. That's why I like the ReGenexx affiliate network, because we have
mhm,
to all
yeah,
submit. Every patient that we have is submitted to the database as far as outcomes, and so we can show these are the outcomes that we typically see in your condition. And I should also plug the ReGenexx webpage, um, because that has a lot of before and after MRIs. ReGenexx with two X's at the end, uh, not three. That's a whole other webpage. No, I'm just kidding. And a lot of just the charts. These are actual outcomes for 6 years. That's how long we ask people how they're doing. Going back a long time.
mhm.
So we have these big databases of outcomes of our specific treatment protocols, MRI before and after. Um, and so you kind of know what you're getting. We do viability testing of the stem cells right in the lab before we inject them. Counts, how many are we actually putting in there? Is that going to be sufficient based on the current body of research to treat your condition? So, yep, we are the premier organization. Premier comes with a price. I'm not ashamed of that as a libertarian, but there are little red flags as far as local places. Like, are they doing counts? Do they know? If they're using a desktop system, are they using the
Mhm.
more recent ones that are getting at least 10x, 7 to 10x, and that oftentimes is sufficient for mild problems? And are they doing a good bone marrow harvest? Are they just because it hurts to get a bone marrow harvest. Are they just going in, slurping stuff out and being done with it? Or are they meticulously getting multiple different areas to get a good amount of actual stem cells? So little things like that, you can kind of get a tell, what board certifications do they have? Are they comfortable doing injections? Are they using X-ray ultrasound guidance? Do they know actually how to get to the ACL ligament? Because that's not something that in med school you ever got trained. I had to do it multiple areas of additional training to figure out how to actually inject the meniscus and the ACL and the MCL and all these different little structures that before it was just a knee joint injection with steroids and hope it works. Now I'm picking away at all these different areas that are torn, because it only works if you can identify the tear and put the stem cells on the tear. So,
Yeah, well, I mean, thanks for going into all that, because, I'm sure people have a lot of questions. So, um, and like you said, this industry, almost any industry that's unregulated, you have people in there who take advantage of that aspect, which is a shame. But, as people who love liberty, and we understand the free market. There's people like yourself, and you know what ReGenerative is doing, which is showing, the proof is in the pudding, having those before and afters, and documenting everything. So in a free market, that
yeah,
that best case, that best practice rises to the top, but people still have the personal responsibility to go out and do the research, and find that. So
exactly.
yeah. All right. Well, Dr. Howard Grattan, thank you for coming on the show. Really enjoyed this conversation. We'll have to
Oh,
do
my
it
pleasure.
again down the road, and get more deeply in a couple of these topics.
All right. Great chatting with you.
All right. Thank you. All right, that is a wrap for today's show. Thank you for listening. Thank you for subscribing. If you haven't subscribed, why not? Why haven't you? If you like any of our shows here on Lions of Liberty, either my show or Lou Perez on Tuesdays, or Brian McWilliams with Mean Age Daydream on Wednesdays, or Brian Nichols on Thursday, or our newest show, Politics, spelled like the blood sucking insect, subscribe. Check us out. We appreciate it. And if you really like our shows, you want more content, you can become a member of our Pricks gang. It used to be the Lions of Liberty Pride. We've rebranded, and Pride members are now Pricks. That's just the way it goes. So I will see you all next week with another great interview. In the meantime, always remember to keep your head up and the fires of liberty burning.